Good afternoon, ladies and gentlemen. Great pleasure to see you, be with you. If you're wondering what I'm doing up here right now, you may have figured I'm your filler between the lunch, and the organizers thought we have 10 minutes, why waste them? They also told me very strictly that in what I was planning to say in the afternoon session, I have to finish now, because in the afternoon session, we have 2 additional exceptional speakers. So you're going to have a lot of fun at 4 o'clock, so I will share these kind of broad thoughts with you right now. So you've probably been hearing this from the morning, that there's just a lot of data. Go back, don't change slides, please. I'll tell you when to change. You've probably been hearing this quite a bit, that there's a lot of data, it's all about the data, everything's in the data. Well, you know what? Healthcare has a lot of data. If it's the automobile industry and their raw material is the steel, and now becoming a lot of the design, it's the architecture or the infrastructure industry, it's the cement and the steel. In healthcare, the raw material is all about the data or the information about the patient. The challenge that we have right now is, while we're drowning in data, we're actually dying for information. We want valuable information about who has the specific gene which makes him more likely to get cancer. Wouldn't Dr. Babsy like to know that? Which medication has a greater efficacy to work on a certain individual and therefore give us better results? How many of us are taking some kind of statin? How many of you are taking some kind of heart-protecting drug? Statins. We have a very young audience, I think. All the older audiences would have their hands up. But do you know that 35% of all statins actually have no efficacy? So we're drugging patients without understanding whether the receptor sites actually work for them, because we don't have the information about a certain precursor gene which is sitting in them. And that also we can find. So the sum and substance is that we need to, while healthcare is drowning in data, we're dying for information. So as I see it, what all of us in this room and the entire industry needs to do is to move this from data to information, from information to the availability of knowledge. How do we extract the appropriate information and translate that into knowledge, and then from knowledge to accelerate discovery so that the science itself improves the entire value chain of healthcare or our healthcare system. To share with you, I'm going to walk through some of these kind of in a representative way. And the first one is really that all of us agree that healthcare is moving from a doctor-centric environment to a patient-centric environment. And the data from the clinic, from the family member who said this patient wakes up every morning at 6 a.m. and vomits, from the small child who says that my dad has this allergy. So from the entire family, the information we're getting, from the kind of data that the patient is looking at or scanning through on the internet, because he subconsciously knows what's wrong with him, from the number of hours he sleeps or he doesn't sleep, from the lab test and its values. So from lab, from insurance companies, from corporates, because you know how many days that person's taking off, from family members, from the individual himself, there's a ton of data. And primarily and most importantly, from the doctors and all the diagnostic work that's happening. If we could collate these data rather than having them in disparate silos, because what the primary care physician knows, the secondary care doctor usually doesn't. And what the tertiary care doctor who did that high-end surgery and took care of this patient for 17 days or whatever it is, and put this in, you know, the blue folder or the patient's chart, which may be an EMR, contained 150 pages, but all that got summarized into a 1-page discharge summary and a prescription, and that's all the GP gets to follow up on the primary care patient. What if we could find a way to create a continuum of care across all these data points and then put a back-end analytics into it? So I'm going to share a few thoughts on this to kind of serve as a baseline. Because very long ago, I heard something which I think is even today extremely relevant. And they said that healthcare is being transformed by 3 Bs. The first B is biology, because when the genome was deciphered, we began this tremendous journey into understanding who's going to get cancer and who is not, who can still continue smoking and won't have a cardiac problem, and who, despite the best of lifestyle, is going to have a stroke day after tomorrow. The genome is telling us this. That's the deciphering of the first B, that's biology. The second B is bytes. With Moore's law making computation more and more and more effective and faster, our CT scans have got better, our MRIs have got better, and our ability to analyze data has got far, far better. And the third, I think, beautiful B is bandwidth, which is connecting the people who you saw lecturing, Professor Latifi, all the way from Arizona, who couldn't come because he didn't get his visa, but also doctors doing telementored surgery. These three Bs are fundamentally changing healthcare. I think I've said this at the last 5 conferences, and I continue to say it because we need to keep our eyes on all three. And that's when we make the radically big changes in healthcare. To just go step by step, the first one for us is data and the tremendous source of it. I'm just sharing a quick insight into what we have at Apollo to make some of these thought processes come alive for you. In the hospital, we approximately touch between the hospital, the clinics, and the pharmacy. We see about 250,000 patients a day. If you take the hospital visits to have an average of, and this is an actual average, about 72 different transactions, and you collate that, we're actually doing over 2 million transactions every 4 hours in the healthcare environment. All these are data points. If we translate some of that again and go a little further into this scenario, which is what are we doing in the rural environment, we will potentially be doing, and some of that is being shown in the stall, telemedicine connectivity into 60,000 sites. So can you imagine the number of transactions and data points we'll be receiving out of that? But how do I use this data? Not just for those one-off points. There was beautiful data when a doctor had a relationship with a patient. Can I make that data more meaningful to the entire ecosystem? Let's look at it some more. So this vast data can become meaningful information. First, if we have a patient identifier. A typical patient comes to us over 27 times. If he's an urban patient living within our neighborhood in his lifetime, and for the last 30 years we've seen that record, and other patients come to us sometimes only once. But those who come frequently, or now the patients who come to us once who are reaching out to us through telemedicine, by creating a UHID or a unique healthcare identifier, we can track the same patient through his interactions from the clinic to the hospital, to the telemedicine consult, to the mobile consults which we'll have, and very soon into the prescription. So I will be building a database of everything that that patient has done in terms of transacting with Apollo in a very simple technology-enabled way, which can be then used for analytics. Besides this, data is also in the operational area. How many patients do we expect to come into health checkup on Monday? Average number, 67. How many patients come in on Saturday? The number could be up to 112. That means I need almost double the amount of staffing. Are we doing dynamic staffing, forecasting, manpower planning, process analysis, because we're converting the data about patients for the last 5 to 7 years, and we can then predict. These are simplistic modeling that we need to start applying into a healthcare environment. So tracking individual patients, looking at process flows can begin to change some of these data points into valuable, usable information which can change decisions in the care pathway or in the operational and the administrative aspects. With this, the hope is that we can create a data exchange because the data capturing is in this standardized format. And for that, you have a beautiful session on EMR. We've done a lot of work on that area. The Government of India has been extremely supportive. I'm happy that people from SNOMED are here to talk about it. My real request is that India can showcase to the rest of the world how we can create a unified data exchange because we're using common standards in our electronic health records. This is really a dream. And then Dr. Ramesh's database and Dr. Babsi's database from ICMR will seamlessly interchange, not only across the Kerala beautiful work they're doing in telemedicine and oncology, but also across onco centers across the country. And this will then seamlessly move in a meaningful manner into the personal health record, into something that the patient can decipher and understand. They will give you data about how the patient's feeling after you gave him that chemotherapy drug, and that will then again come back to you into the EMR whenever that data is relevant. So this ability to have a data exchange, unified, understandable data, which is also valuable for analytics at the back end, is the common dream or vision that all of us need to find ways to work on. Moving on, I think, is the next and one of the most important steps. Taking data into information or meaningful information has happened, but now we need to take data into knowledge. Shouldn't we have predicted the dengue fever that happened in Delhi? Shouldn't we have seen that for 5 years, every single time, starting from March or April, you see this dengue fever trends and it keeps going up? Shouldn't we have improved the fogging? The point that you gave about the Gangetic Plain and the increased incidence of gallstones and gallbladder cancer. These are type of trends that once we understand, then we can, this becomes information that we can act on. You combine it with science, it becomes knowledge, and that knowledge can then go back in to help save people or populations. And the discovery cycle, I mean, we all knew that, found out sometime 5 years ago that in Warangal, because of the lack of iodine, people were having a number of health problems. If we had had data about this, we should have picked up this problem 20 years earlier than we did. We're reacting when the data is staring at our face in terms of death and disability. We should be picking up these trends when they're small. And when we can do this across, I mean, the financial exchanges across the world will track when the dollar comes down by 0.001%, then the effect on 25 different stock exchanges will be known. And 35 different algorithms will be created so you'll know whether to buy or sell your shares. We haven't done the same in terms of spiking of fevers in primary healthcare centers, meaning that a virus is beginning. We haven't created correlations between staphylococcus in hospitals and therefore which antibiotic is going to be the most effective in which season. And pardon me, my CIO is going to get angry when I say that, because that's actually something we've just begun to do. That we are putting together a database of organisms or paths which are growing, antibiotics which are being given, the number of days that that patient is recovering from their fever or reducing morbidity or getting discharged, and creating patterns. This pattern is being presented to the physicians at the point of care. And that's what I mean by data becoming information. The information is all these patients had fever, and that getting translated by collating this into knowledge, and knowledge being given at the point of care. Therefore, we can improve the quality of care that we're giving. This is a very simple concept that I'm hopeful of sharing with all of you today, because I think that if we can correlate all the technology that we build, all the efforts that we make towards patient care, better safety for patients, healing patients, higher value, reduced costs, then our access mechanisms will improve. And that's really primarily what I'm talking about in this. But moving on, I think that the interplay between what we can do is getting more and more exciting. Here is the van which has gone about screening patients for diabetes from Ajmer all the way to Aragonda, which is deep down south, Dr. Reddy's village. And in that we found, besides a series of things, and Dr. Ganapati has a lot more of this data on it, but what struck me was that of all the diabetics that were found, and all of you know that India has 85 million diabetics, 40% of them were unaware of their diabetes. You will find a simple screening tool which is available with non-invasive screening of diabetes. But if we can enhance the link between finding diabetes early and the bigger problem, which is the lack of compliance, by creating a network between the doctor, the knowledge you have on disease adjustment, the counselor, the device, the glucometer, being linked to the phone, and then a remote doctor, and create this circle of care, you will enhance compliance. And that's exactly what the sugar program has done. I'm happy to share with all of you that 80% of patients achieved HbA1c compliance within 90 days of being in the program. 87% compliance rate is unheard of in any other clinical program. And there was no magic done. It was simply using technology, a few empowered people, the doctors gave the guidelines, the counselors talked to the patients in their language and explained to them what a doctor could not do in 10 minutes in his consult room, or what the nurse educator did once but needed to be highlighted again. So it's very, very simple things that you can use for. Screening, medication compliance is a big one. The picture I have down there, I hope all of you can see it. I think it was a very sad day for all of us. Abdul Kalam's birthday was yesterday. You know what struck me about that incident with our honorable past president is that not one person over there stepped up and did CPR. He was a man worth saving. So when we begin to say that life is priceless, then India will find a way to train 1 in 10 people in BLS and ACLS. And this we can do by simply putting the BLS course on everybody's mobile phone. Because more people are playing Angry Birds than they're watching a video on how to do basic life support. So we need to change that, and that will come when the fact that 5.8 crore people are dying due to heart stroke in the world every year. We'll find a way to say, let's create the infrastructure, let's do the more ambulances, and let's create first responders. When we recognize the fact that non-communicable diseases is a tsunami on our population, and we need to change and use IT to change the way we're treating, curing, preventing these diseases. And also, unfortunately, the fact that 2 jumbo jets of babies die every day in India because of diarrhea. It's a simple data point, and all we needed to do was talk about oral rehydration and again put that data on the mobile phone or on the television. So information technology even includes all communication channels. And our knowledge that is sitting inside the 4 walls of a doctor's office has to move into the great wide world using every communication channel possible, because we believe life is priceless. But moving on in this discussion is the great aspect that the big data outside and the analytics that I spoke about will enable us to get the right people, maybe a first responder to save a heart attack, or a doctor with the right medication in the right order, in the right place, at the right time, doing the right thing, and therefore, we will enhance our patient experience or enhance the well-being of the population. Moving on to the last concept I wanted to share was really the entire aspect of taking knowledge that we have and enhancing the discovery cycle by further analytics. And this is a very, very powerful tool. I want to share the story. A young neurosurgeon in our team. So this neurosurgeon does what's, the biopsies when it's called upon for a patient. And he kept saying that it's painful. In about 8% of the people, you cause mortality or morbidity, and this is not the best way to diagnose cancer. So the glioma paradigm was what was really bothering him. So he spoke to the research team. And what you will see here is changing the way the pathway of genomics through liquid biopsy. Because the DNA cell, and here the basic idea is if we could detect cancer before the symptoms occur, because every patient, and if we could detect and monitor that tumor faster and better, because when we're seeing patients, we see them in stage 3 and stage 4. We know that if we got our patients in stage 1, we could make them have a completely, complete cure. So the idea is a liquid biopsy is something like a stethoscope, but this is a cancer stethoscope, and it moves across the whole system because cancer affects everywhere, and it's taken from a droplet of blood. Because the cancer cell, when it starts growing, it is vascularized through blood, and the exosome starts emitting small portions into this blood. if through, and these exosomes as they flow through the body can be picked up, the blood can be picked up at any point. So this is the science of liquid biopsy, of picking up the DNA change which happens, the ctDNA, which is the cancer tumor DNA, so instead of doing a serious brain surgery, the simple thing is if we could draw a drop of blood. And this can happen by back-end using data and analytics. So we analyzed only 5,000 samples, and we have the beginnings of a biomarker. We've done some work on cardiac platelets, and we're beginning to do it now for the biomarker for glioma detection. We've tied up now with a large cancer detection team, and hopefully in the next 12 to 24 months, this product will become something that we can give to the Indian market at 1/20th of global prices. But we can only do this if all of us can work together and find a platform on which we can share our data. So genotype, phenotype, and blood samples and tumor samples, if we can begin to share them across a data exchange, then I think the power of IT and the power of medicine can really get accelerated. And I think we'll do all this because we believe life is priceless. Thank you all so much.